So we're going to talk about managing dual diagnoses. And so here are the learning objectives. I'm not going to go through them too much as we'll talk about them all. One of the things I wanted to cover just a little bit is the importance of geriatric principles. So as we discuss navigating dual diagnoses, the interdisciplinary team is going to be key to that. I find that a little bit difficult in my practice as the interdisciplinary teams, we're probably not as functional as I would like to be, but we're working on trying to get better about those types of things and being a little bit more interdisciplinary. And so trying to work on that, I think, is going to be very helpful from that. Also, consideration of the 5 M's. We talked a little bit about that in the first lecture, talking about kind of what matters most from a nutritional standpoint. Certainly, that I think is, as I describe to people, kind of the overarching umbrella, which I include multi-complexity in that too. So people that have specialized diets, sometimes it makes it difficult sometimes to manage some of those dietary restrictions. And so multi-complexity and matters most kind of overarching help kind of guide what you're going to do from a treatment perspective, whereas medications, mobility, and mentation are kind of more of those are mind, depending upon which one you use, mentation or mind. Those ones kind of focus a little bit more on decisions made. The caregiver plays a key role in all of these things. More so in, if they're at a nursing home, the key caregiver might be different than the one that was at home. And so trying to determine who the caregiver is and trying to support that individual in these things is going to be very helpful. And then professional collaboration goes back to the interdisciplinary team. How does that collaboration look and how do you make that happen? And so I'll try to incorporate that as we move forward through this. So the first thing that I thought would be helpful is how do you diagnose depression in dementia? One thing that frustrates me considerably is the fact that we often use the PHQ-9 in the nursing homes. And we know that 50% of the patients in a nursing home have dementia or some form of memory trouble. And so we use the PHQ-9, which is not great for diagnosing of depression in dementia patients. And so that makes it a little bit difficult. Geriatric Depression Scale, the GDS, can be used. Typically, it's better for somebody that has more mild type dementia. And so not as good for somebody with more severe cases of dementia or more moderate. So if you have mild dementia, you could use the Geriatric Depression Scale. They're supposed to remember back for a week. And so that's why it becomes a little bit difficult in that one. Just like the PHQ-9, they're supposed to remember back for 2 weeks. You can always use the Hamilton Rating Scale for depression, or the HAM-D as they abbreviate it. So that one has been shown to be fairly effective in diagnosing dementia and depression in dementia, and so would be a good scale to use. It's more of a caregiver-based approach, and so that's helpful from that side of things. And then, so you'll see that used in a lot of the studies that if you're looking for how do you treat depression and dementia, you'll see the Hamilton Rating Scale for depression being used to help understand how that is being affected. The Cornell Scale for Dementia and Depression, or CSDD, is also very effective. And then I did read something about a clock drawing test, maybe helping you understand depression. And when you look at the notes, it'll say in there, people that have depression and dementia have a significantly lower score on the clock drawing. So if you have a lower score on the clock drawing test and you have some dementia, that may suggest that there is a component of depression with that. And so that might be something helpful to you if you're using like a mini-cog for a screener, or if you're using a MOCA or a SLUMS. Doing the clock drawing test may help you understand if they have a very low score that maybe I also need to think about depression here. Most of us, I think, that treat dementia are also screening for depression as we're treating dementia, as we do know that's a secondary or a reversible cause of dementia, which I think is a misnomer term because it can't be a reversible cause of dementia at this point anyway. It's a different thing. It's depression as opposed to dementia. They also have difficulty copying and reading. So if you're doing something with copying and reading, those people with depression probably have a little bit lower score on those testing items as well. And then you can always use the DSM-5 or DSM-4 criteria to help you understand if they have dementia or depression when they have dementia. Though that's not as easy to use, I don't think. And so having one of those scores, I think, is very helpful. Now we're going to move on and talk a little bit about how you treat depression and dementia, because I think that's going to be the biggest thing, is how do you get these people better? And unfortunately, as I was doing a lot of this reading and studying about this, I was like, oh my goodness, it's not easy. I always thought, oh, it's pretty easy to treat depression and dementia. But then as I was looking, a lot of the things that we use for standard treatment of depression is not as effective as it is for people with dementia as it is for people with just depression alone. I typically have divided this up into two different sections. So there's the non-pharmacologic treatment and then the pharmacologic treatment. I typically discuss the non-pharmacologic treatment first, and then we'll discuss the pharmacologic treatment afterward. Most of the articles that I reviewed for these are review articles on depression and dementia, anxiety and dementia, and then the last one we'll talk a little bit about is psychosis. I did look at a couple articles on bipolar disorder and dementia. There wasn't a lot of good information on those. They were kind of a little bit smaller studies, and so did not include any of that information, but certainly we can talk about it over time if we want to. So non-pharmacologic treatment for dementia, again, thinking about the geriatric principles, this is where the caregiver support, the interdisciplinary and intercollaboration is extremely important, because all of these things need to work in harmony together in order to work. So music therapy is something that has been shown to be very helpful in people with depression. When they did some of the music therapy, you don't have to, it's not very difficult to understand what music therapy is. Some of the studies that they have done were 15-minute interventions. So they did 15 minutes of music therapy twice a day for 6 weeks, and they showed an improvement in their depression scores with that. There are some that didn't show any improvement, and so that also makes it a little bit difficult, because that's kind of a mixed result. So when you're thinking about music therapy, you need to think a little bit about the fact that there are some positive studies, some negative studies. The intervention wasn't really long, 15, 30 minutes of therapy, daily, maybe for 5 or 6 days of the week. And a lot of them used either live music. So they actually had somebody coming in to do that, and I don't know how you do that. And then some of them just had video, and some of them just do listening to music on an iPad Nano with headphones or something like that. And so the therapy was a little bit varied. I didn't see much difference between those therapy sessions, so it didn't really matter too much, though maybe live music was a little bit better than the others. And some of the live music ones, they only did once a week or maybe twice a week, so that they didn't have to have a live musician there all the time. They did compare one time live music with video music, and there was a slight difference, live music again being just slightly better. Cognitive behavioral therapy, that's something that I find difficult to find in a lot of my treatment areas. I don't have a lot of psychologists in Sioux Falls that do a lot of cognitive behavioral therapy, and so it's a little bit difficult. The studies on this, again, actually probably are a little bit more negative. Cognitive behavioral therapy is certainly one where they kind of look at how to manage thoughts, feelings, and behaviors, do some coping mechanisms, and I could see where people with dementia probably have a little bit harder time with that. You might be more successful in people with moderate or mild dementia, so somebody that has early onset, not having as much dementia. Cognitive behavioral therapy may be something that would be effective, and so I couldn't tease out in those studies whether mild and moderate and severe made a difference, but it didn't seem like the studies were as effective for cognitive behavioral therapy. And you can understand that, because it takes them to remember some of the coping strategies and try to use them on their own when they're away from the therapist. And so that can be challenging in somebody that has some difficulty with memory. Exercise is extremely helpful in depression and dementia. I think it's also extremely helpful just in depression in and of itself. And so people that exercise more have less depression. And the exercises that they did in a lot of these studies were not, again, long sessions. They were more like the music therapy, where they did 30-minute sessions, and they did that over, daily for 5 days or 6 days. They didn't go outside. Some of them were chair aerobics. Some of them were just, doing like the new step or something like that. And so exercise has been shown to reduce some of those depression symptoms. Again, I think there's a little bit of a mixed picture. Some people, if you think about what matters most, some people don't like to exercise. So by forcing them to exercise, you're probably not helping any of their symptoms or depression. You're only making them more angry. But some people do like to exercise. Most people like to exercise. And so exercising is extremely important. Again, evidence is a little bit mixed on exercise. Sleep hygiene, as we all know what sleep hygiene is. I'm not going to necessarily go through what the sleep hygiene recommendations are, but sleep hygiene is not really been shown to be that effective at helping with depression and dementia, but does have some evidence that may be mixed, that it may help a little bit. And so it could be something you could try. I typically try that more in people that are having trouble with sleeping. So if they come in and tell me that they're depressed and demented and having trouble sleeping, then I go through sleep hygiene with them. Again, trying to remember all the steps is difficult. This is where having the caregiver as part of your team, where you can say, hey, we need to work on some of these things from a sleep hygiene perspective. Same with exercise and music therapy, just saying, we need to do these things and see if we can get them improving is kind of the way to go from that standpoint. I'm just going to see most evidence supports a little bit of that, but not too much. And the best evidence probably is more bright light therapy from a sleep hygiene perspective. So having somebody use bright light to try to help during the daytime to help them sleep a little better at night. Neurostimulation is kind of more of a way to get to activate people's brain to try to get it to work a little bit more. That again has mixed results. I have music therapy on there twice. I'm not sure, partly because one of the articles I read had music therapy and art together, and I separated them. So art and music therapy, and part of the reason I separated them is because the music therapy and those articles that had music therapy and art together, music therapy was effective, art was not as effective at doing that. Art therapy was done in different ways. So sometimes it was somebody bringing in a piece of art and then reviewing that piece of art and talking about it. Some of it was actually going to a museum and just wandering around a museum. And again, that therapy was done once or 3 times a week, kind of depending upon the type of therapy. The art therapy was done, and that art therapy, if they were bringing the art in, was done a little bit more regularly than if they were going out to the museum. And again, mixed results on that as well. Cognitive stimulation, very similar to neurostimulation, though a little bit different based on what they did in the 2 studies. So the cognitive stimulating group, again, mixed picture with same about the neurostimulation. They're about similar activities, but just a little bit different way to do that. Reminiscent therapy probably has a little bit better evidence. So the reminiscent therapy, they take them back to some of the things that they remember as a youth or a child. And that reminiscent therapy sometimes was extremely helpful in getting people to kind of come out of some of their depression. I find that probably more as a way to redirect people from behaviors, probably more so than helping with depression totally. Some of these studies that they did with that, they did reminiscent therapy, 1 session daily for 5 days or maybe 6. And so mixed picture with that, and sometimes they did that in group therapy, sometimes they did that in individual therapy, and whether they did it in group therapy or individual therapy really didn't make much of a difference. Animal therapy, they sometimes will bring animals to the individual and see if that would help. Certainly there's some evidence that animal therapy works. I get asked quite regularly in my clinic if I can write for a therapeutic animal. Some of that probably is due to the need for apartment rules to have an animal in the home. But when you look at the literature, there is a little bit of evidence that that works. And again, same thing from a dementia and depression standpoint, animal therapy does seem to help. I didn't put this on here just because of the fact that it doesn't make sense with everything else that I had on here. There was another study that I looked at that did 10 different types of interventions. So they did animal therapy, they did cognitive stimulation, they did exercise, they did massage and touch therapy. They also looked at reminiscent therapy, and then a multidisciplinary care type approach with occupational therapy, cognitive stimulation, and medication. And so that therapy, again, had mixed results. So unfortunately, not a lot of evidence from a non-pharmacologic treatment of depression and dementia that were real positive. It's not like any one of these was like, oh, really, that's going to be your key go-to. If I was to say what I would try probably the most is going to be some music therapy. That probably has some of the best evidence, as well as potentially some exercise therapy as well. So, and then maybe adding in a couple of the other things, kind of depending upon what you're seeing. So if you feel like they're understimulated, doing some neurostimulation or cognitive stimulation may help with that. If you're finding that they're having difficulty sleep, maybe working on sleep hygiene as a little bit of that. If they like to reminisce, if it's something that, you know, you find that when you're going to visit with them and they're always wanting to talk about past events and those types of things. In fact, I just saw somebody yesterday that I ended up having to cut our visit a little short because of some of the other things that I had going on through the day. And he was like, I really like our discussions and it feels like it helps me quite a bit. And some of that he likes to talk about past and those things that happened to him in the past. So reminiscent therapy may help him from a depression standpoint better than some of the other things. And so that's how I would do it typically in this situation, is looking at those types of things. From a pharmacologic treatment, we have all of these different types of medicines that have been tried. Some of these I've never tried in my practice. Female sex hormones, I wouldn't have ever thought about doing that, but there is some literature on that, and some of the review articles that I read included those types of things in the article. So the main category that you think about are the selective serotonin reuptake inhibitors, or SSRIs. That's going to be the most commonly used treatment for depression and dementia. And when you look at these, really, it's quite surprising that some of the studies didn't show that they were that effective. Now, a lot of them use some of the older imipramine and chloripramine in some of these studies, and so that makes it a little bit more challenging. And so some of the newer ones like sertraline and citalopram may not have been used as much, but still the results showed that sometimes there was, usually it crossed the confidence interval of 1, so either it was not as effective as placebo or not. So they did, you know, in one of the studies, they had a 2.12% improvement, or 2.12 improvement in their depression on the scores, but it crossed the confidence interval at 95% to 0.95 to 4.7. So hard to say whether or not those are effective. And most of the studies are mixed. Probably the best studies, citalopram may be a little bit more effective than some of the other SSRIs. So if you're looking at that, citalopram may be the most effective. Sertraline, again, those studies were also mixed. You have the serotonin norepinephrine reuptake inhibitors. Those ones also, again, mixed studies. Sometimes they did the SSRIs with the SNRIs. And so that also threw me off as to why they included both of those into those things. And most of those studies were mixed. They did the HADSAD trial, which they did 389 patients. It was a several week study. sertraline with placebo and mirtazapine. So it was sertraline, mirtazapine, and placebo, and they separated them out into 3 groups, and neither drug reached significance in all participants. All participants improved, so even those in the placebo arm had less depression by the end of the study. And so, again, hard to say. You had more adverse reactions in the sertraline and the mirtazapine group. And so, again, when you're looking at NSAID or the SSRIs, SNRIs, a lot of mixed data on those types of things, so it's hard to say. Bupropion was also mixed. I think you found a little bit more falls in the bupropion groups when I've looked at some of that information. So there wasn't too much improvement in their depression compared to placebo, and there was probably a little bit of increased in fall risk. And we'll see that a little bit more. I did talk a little bit about treatment-resistant depression in dementia, as there was a new study that came out here recently on that, and they used bupropion as their alternative type drug treatment, and they found a lot more falls in that group. Mirtazapine is about the same. Again, the sertraline, the HATSAD trial was pretty mixed. Some people use acetylcholinesterase inhibitors, donepezil, rivastigmine, galantamine, and most of those studies, again, hard to say, but a lot of them had mild improvement, and again, usually crossed the midline or the one to show that it really was not as effective as what we would like to think. There may be a little bit of evidence for cholinesterase inhibitors, but again, kind of mixed. There was one study that combined the acetylcholinesterase inhibitor with the selective serotonin reuptake inhibitor, and that seemed to be a little bit more effective. And the one that they combined it with was sertraline. And so maybe combining those two would be effective. They've tried memantine. Memantine really was was about the same as the acetylcholinesterase inhibitors. I didn't see anywhere they mixed memantine with one of the SSRIs or SNRIs. I probably didn't look hard enough for that. There probably are some studies out there, and I would guess that it would probably be a little bit more effective than either one alone. Antipsychotics. So a lot of the studies that I looked at were some of the newer ones: olanzapine, quetiapine, risperidone. That study showed little benefit and much more side effects. So again, recommended against use of antipsychotics in this situation. Mood stabilizers have also been tried, and most of those, again, were very similar to the antipsychotics. No real benefit, and then increased adverse reactions. Interestingly enough, somebody tried antimicrobials for treatment of depression and dementia, and some of that was when I was looking, there was some thoughts that maybe rifampin would help reduce the buildup of amyloid and or tau plaque, and or doxycycline would do the same. When they did that, they didn't see any improvement in dementia progression, and they did not see any improvement in depression itself. And rifampamine actually probably made depression worse. So when you're looking at that, the two studies that were studied were doxycycline and rifampin, hoping that it would also help maybe reverse a little bit of the memory loss. We know that it didn't reverse any of the memory loss, otherwise we'd be talking about it more, and the rifampin may have made the depression actually worse. They've tried the female sex hormone with estrogen, and they did 65 women, 12 months, no benefit in the primary analysis. Secondary analysis showed a little bit of improvement in the geriatric depression scales and those that had higher education. So maybe in those that are highly educated, maybe it would work, but most of it was negative. They also found it a little bit more effective in people that were non-carriers of the apolipoprotein E4 allele. So if you have that allele, maybe it would be effective. I don't often check the ApoE4 allele, so I don't know how I would determine those that would be right for use. And then they've also tried some pain medications. This was tramadol, hydrocodone, or Tylenol alone. And again, mixed results on that. Really didn't see much improvement. So from a depression and dementia side of things, a lot of the evidence is pretty weak. You probably have your best evidence for probably an SSRI, maybe a little bit of the SNRIs, bupropion, mirtazapine, a little bit mixed. Bupropion may cause a little bit of increased falls, and then maybe combining that with acetylcholinesterase inhibitor or memantine may give you the best benefit from that side of things. Now, so if you're having trouble from that side of things, maybe switching would be helpful. And so there was a recent article here that was, I think, published in the New England Journal of Medicine about augmentation for treatment-resistant depression, and that was people that have tried one or two antidepressants for a long enough trial. So as people that were on, let's say sertraline, and they did that for several weeks or months, had no effect, and they were at a usual dose for sertraline, or they were on a different one and had no benefit from that side of things. They wanted to enroll about 1,200 patients. They were only able to enroll about 619 patients. 248 of them moved on to step 2. So initially they did an augmentation, and then they switched to the switching group, or the step 2. So step 1 was augmentation, step 2 was switching. Interestingly enough, some of them started right out in step 2, and that was partly because they'd already tried like a bupropion. A lot of them didn't try aripiprazole or lithium, but they added, so if they had tried bupropion, then they moved right into the stage 2 trial of that. There wasn't too many that, I guess 123 were directly enrolled in stage 2, so a little bit more than what I was thinking. The direct enrollees in step 2 either failed one of the step 1 medications. We already talked about that. They had, on average, tried about 2.3 medications for depression before enrollment. So most of these patients had tried some type of depression medication before enrollment. 70% of the patients were adherent to the augmentation trial. So they augmented with aripiprazole, they augmented with lithium, or they had bupropion alone. And so those are the 3 groups that they had when they did the augmentation. So that was the stage 1. And they looked to see and so 70% adhered to the treatment, 40% were adherent in the bupropion group alone. And in the switching group, when you went to the second stage, they only had about 50% adherence to that medication regimen. So it's a little bit hard to say how effective it is because they didn't have great adherence to the medication. When you look at the aripiprazole group, the improvement in their psychological well-being was 4.83 compared to the non-treatment group. And the confidence interval on that was 3.28 to 6.38, showing that probably was a little bit helpful from that side of things. They also looked at side effects from that. I think what they did is aripiprazole plus bupropion, lithium plus bupropion, or bupropion alone. That's the augmentation group. When they did the other one, they did bupropion alone and then switched with nortriptyline. And so when you look at the side effects to that, the aripiprazole group actually didn't have a lot of severe side effects, which is kind of surprising to me. But they seemed to tolerate the medication fairly well and did not have a lot of difficulty. The bupropion only group was found to have more falls, and so that was something to be aware of. There was no difference in the lithium and bupropion group when it came to improvement in depressive symptoms. When they did the switching trial, when they switched them to either bupropion alone or nortriptyline alone, there wasn't a lot of difference between the two. They found maybe a 15% improvement in depression in that trial. Nortriptyline was 21.5% according to this, and 19.3% in the bupropion alone group. And so hard to say, and that crossed the confidence interval. So probably not more effective in switching. And so augmentation may help in depression if you're having difficulty. Aripiprazole may be the safest option. Lithium is a little bit more difficult, though it didn't seem like they had a lot of adverse effects in the lithium group either during that trial. And then bupropion alone probably increases risk of falls. And if you want to switch to nortriptyline, if all other options have failed, there may be a little bit of response. So if you tried your SSRIs or SNRIs and you've tried to augment them with the acetylcholinesterase inhibitors, augmenting with aripiprazole may be effective. And if none of that works, finally switching to nortriptyline or bupropion alone may be effective if you haven't used either one. Okay, let's see. Can I look at the chat? I'm going to see if I can find.
There are a couple of questions.
There are, yeah. So sorry, I did not have the chat open, so I opened it now. So it says, while music therapy is known to be effective, we have to be careful to not overstimulate. Any suggestions? I think that's why a lot of the trials were short. So again, you don't want to be putting music therapy on somebody and letting it sit there for hours on end. I think keeping the duration of the music therapy a short time is probably the most effective approach from that side of things. So you're right that you don't want to overstimulate. And so also making sure you regulate the volume. So if you're going to have live music, you don't need to be setting up, like a big rock band. I went to a play the other day and I sat right in the middle and oh my goodness, I was like, I don't know if I can stay here. I'm being overstimulated by the music. It probably wasn't overstimulation. It was just that it was so loud. I was like, I just can't handle this. And so controlling the volume, controlling the duration, and making sure you're not doing too long. That's the things that I think help with that. You think the lack of effectiveness of interventions, pharmacologic, non-pharmacologic, because we misclassify dementia symptoms as depressive symptoms, example, apathy and withdrawal. I do think there's probably a little component of some of that in the fact that we are misclassifying them. I think part of that is some of the ways that we classify depression. And so it's becoming a little bit difficult to say if they have depression or if the symptoms are depression or dementia. And so yes, I do think that some of that probably lack of efficacy is some of that. I don't know if that's the whole picture here or not. Some of that may be that the way these medications work doesn't work the same in somebody with a dementia brain as opposed to somebody without a dementia brain. And so that could be some of it is there's probably some things that we don't understand regarding that. So I do think we have to be a little bit careful. So some of it may be misclassification. Some of it may be actually some of the brain changes that are going on in dementia that make the depression symptoms harder to treat. So hopefully that helps answer that question. Okay, now we're going to move on to anxiety. So there's a couple, again, we'll talk a little bit about how to diagnose anxiety and dementia. I'm not going to go through it too much. Behavioral pathology and Alzheimer's disease scale, or the BEHAVE AD. There's 7 domains. It's a caregiver interview. It works pretty effective. And so if you're having trouble deciding if there's some anxiety, doing this may be helpful. Neuropsychiatric Inventory, or NPI. This is the one that I think is more commonly used in a lot of the studies. So maybe a little bit more effective. At least it's the one that I saw most often when I was looking at the studies. That's the one that they used. It's 10 domains with 2 added recently. So there's actually 12 domains. And then again, it's another caregiver interview type style. The Rating Anxiety and Dementia, or RAID, is a 20-item scale that I've also seen to help understand anxiety and dementia. And so maybe something that would be helpful. The worry scale is self-reported. So this is something that you can take to yourself and try the worry scale yourself. And then, of course, using the DSM-4 criteria is always helpful. They haven't tried as much non-pharmacologic treatment for people with anxiety disorder as they did with depression. You saw how many different trials there were with different approaches. And again, anxiety has a little bit less. I find sensory stimulation to be kind of an interesting one because people with anxiety have a tendency to have a much more difficult time with the sensory stimulation, but they still tried it. Music therapy, again, was found to be fairly effective, though they had a minus in one study that they did. They had a minus 1.92% lower score on they actually did the Hamilton Anxiety Rating Scale, which has not really been one that's been great for anxiety. And I don't know why I didn't include it on the above slide, but and that did cross the midline. So again, music therapy and anxiety may not be as helpful. I actually just probably a month ago, I recommended one of my patients with dementia and anxiety, to start some music therapy. They haven't started it, so unfortunately, I haven't seen what the results were because they were having a difficult time getting the music to them. We were going to try an iPod Shuffle, and I don't know what the challenge was, but um, you don't. They don't sell a lot of iPod Shuffles in the local store, so I think they had to order it online, and they were waiting for it to be shipped. And so music therapy, again, the results are a little bit mixed. Sensory stimulation, some of what they did from that was auditory stimulation, visual stimulation, tactile stimulation, and then they did some olfactory type stimulation. So they did all of those types of things. So they just, either played sounds that would be familiar to them. They looked at pictures or art that was familiar with them. They did some tactile things where they felt different objects that seemed familiar, and then they also did smells that they thought would be familiar. And so they tried that in a couple studies, and again, these were 20-minute interventions that they did daily and not too effective. They also did another one where they were doing the sensory stimulation that they used a doll. So they had a doll that they had them use for 30 minutes 3 times a week for 3 weeks. And then they also used the robot seal, or the Paro, P-A-R-O, was the robot seal. And again, this crossed the midline, so did not seem to be that effective. The improvement was minus 0.21 compared to the control group, and then it was the confidence interval was minus 7.4 or 0.74 to minus 3.3. The heterogeneity in those studies were quite high, and that was somewhat because of the fact that they did totally different interventions. So one of them used the robot seal, one of them used a doll, and the other one did olfactory and the other stimulation. So a little hard to say if sensory stimulation was effective. Some of those studies showed that the original studies on those did show that there was some effect. Again, you have the same cognitive therapies here. So some of that is cognitive behavioral therapy, as we talked about with depression. So sometimes that is helpful. There was a study on dignity therapy where they try to restore some of the patient's dignity. Certainly you lose some of your dignity when you become demented. And so trying to help restore some of that dignity would be helpful. They did that. When they did the dignity stuff, it was 2 interviews or activities over a week time frame. And again, that crossed the midline, so probably not as effective. They did some muscular approaches, and those muscular approaches were kind of just range of motion type activities. They did ear acupressure in one, and they did adhesive herbal seeds. And what they did is they basically took the herbal seeds and they'd kind of push them into certain points on the person's body. So that was one of the interventions they did. Some of them they did just motor hand skills and relaxation and massage types therapy for muscular approach. And again, that crossed the midline, so it was hard to say whether that was effective. And the control group in those were taped imaging techniques and conversation. And again, not much difference between those. And then they had one where they combined the stimulated cognitive activity and physical activities, seeing if maybe the 2 approaches together would be more effective, because there was some evidence in the initial studies that maybe a cognitive approach or maybe a muscular approach, physical activity approach would be effective. So they said, let's combine them and see what happens. With that, they did the Go game. I don't know if you're familiar with the Go game, but that was one thing they tried. One of them that they tried was music with movements. So they tried to do music therapy where some of them even participated and made the music themselves. So they would, like, okay, now you can play the drums or you can do this or you can, and so, and some of that was tele-rehab. Some of it was dual exercise, chair-based. And so, again, cross the midline. So maybe a little bit of an effect, but not as much as we would like to see, or I would like to see. Anxiety pharmacologic treatment. You have again, about the same types of medications that they used in depression, though a little bit less. You'll see that they don't have quite as many studies on that as some of the other ones. And ginkgo biloba, which is down here on the bottom of the slide, but it was one of the first ones that they said, actually did show a little bit of significance. It was 240 milligrams of ginkgo biloba, and they did that for basically 24 weeks. It was 810 patients, and the intervention showed a minus 1.1 reduction in their anxiety scores, whereas the control group was only minus 0.6. And they said the p-value was 0.004. The actual effect size couldn't be calculated because it was kind of a small study and they had some missing data. So they didn't really, they said that maybe ginkgo biloba has a little bit of improvement, but not clear based on the couple studies that they included. And it seemed like only one. SSRIs, they mostly looked at citalopram in that, and again, there was a little bit of improvement. The odds ratio was 0.43 for an improvement in anxiety from baseline, and that was a confidence interval of 0.22 to 0.84, which is a p-value of 0.01. So they said that that was statistically significant, and so citalopram may be your best option from an anxiety standpoint in treating people with dementia. Antipsychotics they used, and again, some bit of improvement, but the side effects they felt like were too great to be considered something that they should do all the time. Probiotics, they also tried, seeing if that would be somewhat effective, and we heard a little bit about some of that. Nutrition-wise is probably somewhat helpful from that side of things. And they did see some significant difference, but they said the risk of bias in the studies was quite high, and so they couldn't recommend using probiotics. Benzodiazepines, most of the studies that I looked at actually did not include any benzodiazepines in their treatment. So that's kind of interesting. Most of us, a lot of use of benzodiazepines out there for anxiety, but none of these studies for dementia looked at too much with benzodiazepines and anxiety and dementia. There's probably some bit of improvement in that, but the side effects and risks probably are more in line with the antipsychotics, so probably the risks of that treatment outweigh the benefits. Any other questions about that? I didn't see anything in the chat, so I'm assuming that we're good and we'll just move on. Now we're going to get to the last part, and hopefully I'll have just a little bit of time for questions at the end. Probably won't have quite as much as I was anticipating. I don't usually have very many slides, and I talk too much on each slide. So psychosis and dementia, this is a little bit more of a mixed. It was a little harder to find some non-pharmacologic treatments for this. Again, they used similar treatments to all the other ones, and some of these were not typically used just for psychosis. Some of them were used for more behavioral disturbances in people with dementia, so that made it a little bit more difficult. Occupational therapy activities, so just like it sounds like, they tried Taylor occupational therapy, and that was shown to be improvement in shadowing. So where the dementia patient was following the workers around and shadowing somebody else or shadowing one of the other residents, they did show a little bit of improvement with that with occupational therapy activities. Music therapy, this one, again, was more helpful in reducing the behavioral symptoms more so than psychosis, which you would expect. And the same types of therapy, they did the same length. They did try aromatherapy to see if that would help, and lavender, and they compared lavender to sunflower oil, because sunflower order doesn't have a lot. They also did that same type of acupressure where they put the aromatherapy on a certain spot in the body and then press that in to see if that would help. And there was maybe a little bit of improvement in behavioral disturbances in those with the lavender group controlled to the compare group. And some of that was um, not much different than when they compared it to there was no difference when they looked at just lavender alone compared to donepezil and no or placebo. There was maybe a little bit better when they did the acupressure group. Um, Bright light therapy they tried. Again, probably not that helpful, though maybe a little bit of improvement in that. Touch therapy they also tried. There was a little bit compared to no touch. They did say that was significant, but it was a small group and didn't feel to be something that should be used too much. Combined activities. This was done in Taiwan amongst Chinese men, and they did music therapy with orientation training, physical exercise, and art cognitive activities that was delivered by a trained occupational therapist, 12 weeks. And they had a little bit of improvement in delusions with this and hallucinations and agitation. The p-values were 0.018, 0.004, and 0.038 for agitation. So all of those being effective. So maybe doing a combination of activities would help with some of that. I found it interesting that it even helps with delusions, as I find those to be somewhat difficult to treat in my own practice. And then they also tried cognitive rehabilitation. This included a 4-week home intervention, so this was done actually at home. It was 45 to 60 minute sessions twice a week, and they did memory techniques, origami, computer training, TV remote control training. So how to use your TV remote, how to use a computer. And they had a reduction in delusional symptoms with large effect size, as well as aberrant motor behavior increased, though. So what they found is the delusional symptoms improved in the cognitive rehabilitation group, but their motor symptoms significantly increased. And so you might be able to help the delusions, but maybe not help with some of the other behavioral symptoms. Now, when we look at pharmacologic treatment for psychosis, you obviously have the typical antipsychotics and the atypical antipsychotics, or first generation antipsychotics and then second generation antipsychotics. There was some studies on cholinesterase inhibitors as well as memantine. And I guess we have just a couple more minutes. So the typical antipsychotics showed the most effect for people with delusions or hallucinations or psychosis as the true psychosis. And so that was the first generation antipsychotics, Haldol. And so that's the thing that you want to think about. And then the atypical antipsychotics really didn't show any difference between the placebo arm. You had more somnolence with both of those two treatments. Cholinesterase inhibitors really didn't show much improvement either way.